GI pathology, jaundice, benign neonatal hyperbilirubinemia, biliary atresia, and hereditary hyperbilirubinemias. All right, so first and foremost, let's discuss jaundice. We already talked about the whole process in which jaundice occurs, right? It's just going to be a large distribution and deposition, I should say, of bilirubin throughout the body, okay? And you're going to be usually seeing yellowing of the skin or the sclera. So when they say scleral icterus, they're just talking about yellowing of the sclera. That's usually the places that you're going to see them the most. Now, the common causes of increased bilirubin is going to be 1, hemolysis, 2, obstruction, 3, tumor, and 4, liver disease. So those are kind of your main causes of jaundice in patients. So let's talk about conjugated or direct hyperbilirubinemia. So what you're going to mainly see for conjugated or direct hyperbilirubinemia, remember that this is going to be not a problem at the liver, right? Because the liver has been able to conjugate it. So it's going to be usually some type of biliary tract obstruction. So it could be a gallstone or something causing like some type of cancer, like a pancreatic or liver cancer. It could also be due to some type of biliary tract disease like primary sclerosing cholangitis, PSC, or primary biliary cholangitis, PBC, which we'll talk about later on. And then it could also be an excretion defect, which we'll talk about in the hereditary hyperbilirubinemias. But that's going to be like our Dubin-Johnson syndrome or our Rotor syndrome. For our unconjugated or indirect hyperbilirubinemia, this could be due to just the liver being overwhelmed in patients that have like severe hemolysis. It's going to cause a severe increase in unconjugated indirect hyperbilirubinemia, which the liver cannot keep up with. You can also see Crigler-Najjar or Gilbert syndrome, which we'll talk about in a little bit, which is a decrease in the ability for UDP-GT to conjugate the bilirubin. So next is going to be our benign neonatal hyperbilirubinemia. The reason they call it this is because it's benign. So usually it's physiologic for a neonate to have jaundice. They will have mild unconjugated hyperbilirubinemia. It's usually due to the fact that babies or neonates have an increase in fetal red blood cell turnover, and they also have an immature newborn liver, so they don't have a UDP-GT activity as good as ours as adults. And then they also have a sterile newborn gut. So that means that they have a decrease in conversion to urobilinogen. So you have an increase in deconjugation by the intestinal brush border cells, and it causes increase in enterohepatic circulation. Now, there's something known as beta-glucuronidase. Beta-glucuronidase is just a lysosomal enzyme that causes direct bilirubin deconjugation. So patients that are breastfed, breast milk, also have some type of neonatal hyperbilirubinemia due to the fact that beta-glucuronidase, which deconjugates direct bilirubin, is in breast milk. Okay, so I hope that makes sense to you all. Now, what they want you to know is kind of how you treat it. What we're afraid about is if we have too much bilirubin, especially in a child, that's pathologic, not physiologic, but pathologic, we're afraid that bilirubin is going to build up and store in the basal ganglia. Okay, and this is known as kernicterus. So kernicterus is just the deposition of unconjugated bilirubin in the brain, specifically in the basal ganglia. And they want you to know that it's basal ganglia. So to avoid this, what we do is we put these babies under light, specifically non-UV phototherapy is what we call it. And it isomerizes unconjugated bilirubin to a water-soluble form. It doesn't necessarily conjugate it, but it helps it become water-soluble so that it can be released. All right, so a couple things to think of. A patient with benign neonatal hyperbilirubinemia, they have an elevated bilirubin production, they have decrease in bilirubin conjugation, and they have an overall elevation in enterohepatic biliary circulation. Okay, does that make sense? The elevated bilirubin production comes from the fact that there's an elevated fetal red blood cell turnover. All right, the decrease in bilirubin conjugation is due to the fact that they have immature newborn livers, so they don't have good enough activity of UDP-GT. And lastly, the increase in enterohepatic biliary circulation is due to the fact that they have elevated levels of beta-glucuronidase from breast milk or just from a sterile newborn gut. So that leads to the conjugated bilirubin being deconjugated again while in the GI tract. And so then that means that they're going to get reabsorbed. So you'll see an increase in that recycling process. All right. Lastly, remember, we're worried about kernicterus, and that's just bilirubin-induced neurological dysfunction because of the deposition of it in the basal ganglia. All right, and you're going to treat them with phototherapy. That's all you need to know for benign neonatal hyperbilirubinemia. Next, a high-yield association with children is biliary atresia. So let's say that the newborn comes in, but they still have jaundice, persistent after 2 weeks of life. That's pathologic. We should expect patients to have their jaundice resolved after 2 weeks. So if a patient has 2 weeks of life and they still have jaundice, that means that there's some type of pathology going on. Now, if you ever see a patient with jaundice after 2 weeks of life, and they have dark urine with acholic stools, which just means pale stools, the answer is going to be biliary atresia. And I remember I rarely ever say 100% of the time, but for me, this is 100% of the time. If you see acholic stools, dark urine, along with prolonged or pathologic jaundice in patients or in newborn patients 2 weeks after life, it's going to be biliary atresia. And so what does that mean? That means that there's an extrahepatic obstruction of bile ducts. Okay, so you don't have the bile ducts pretty much made, biliary atresia. The bile ducts are not created. So there's an extrahepatic obstruction. So outside of the liver cannot drain its bile ductules into the actual bile ducts of the biliary system, okay, because they're not created. So that means the bile cannot get from the biliary tree, so from the liver, to the GI tract, to the duodenum. So that's why you're going to see pale stools and darkening of the urine, because we can't have urobilinogen get into the duodenum, where it can become stercobilin and cause stools to have a dark brown color. And it can't get all the way, think about it, to the kidneys, where you'll have urobilin, which gives urine its yellowish color. Okay, so that's why you'll see darkening urine and acholic stools or pale stools with biliary atresia. Okay, very high yield to know. Now, lastly, we have our hereditary hyperbilirubinemias. Very easy. Okay, these are all autosomal recessive. The first one you're going to see is Gilbert's or Gilbert's syndrome. People say it differently. And all that this is that you'll have a mild decrease in UDP-GT activity. Okay, and remember, UDP-GT is what conjugates our bilirubin. So if you have a mild decrease in UDP-GT, the patient is going to be asymptomatic because it's just a mild decrease in the activity, unless something stressful happens and it leads to an increase in the amount of unconjugated bilirubin. When you have a large amount of unconjugated bilirubin, then you're going to start to see abnormalities and jaundice, because the patient has a mildly decreased level of UDP-GT, so it can't keep up with a large amount of unconjugated bilirubin. Does that make sense? So whenever a patient comes in with mild jaundice only in times of stress, so only in times of stress they have mild jaundice, then you know that it's some type of Gilbert's disease where it's just a mild decrease in UDP-GT, okay? And they're going to see an unconjugated hyperbilirubinemia, okay? But it's not with overt hemolysis, right? Next is Crigler-Najjar syndrome. Crigler-Najjar is the severe form of Gilbert's disease, and this is absent UDP-GT. The patients, once again, are going to have like severe jaundice, severe unconjugated hyperbilirubinemia. It's very, very high levels of unconjugated bilirubin because, once again, you don't even have UDP-GT to even conjugate it in the first place. So the patient's going to have kernicterus from this unconjugated bilirubin, which deposits in the brain. They're going to have severe jaundice, and it's very, very scary. So the patient's going to have to undergo phototherapy and plasmapheresis. They're going to probably have to get a liver transplant to cure this, okay? Now, those are your two types of unconjugated hyperbilirubinemia, Gilbert's and Crigler-Najjar. Now, your two types of conjugated hyperbilirubinemia are Dubin-Johnson and Rotor syndrome, and these are less severe. And all that both of these are is an inability, essentially, for, I guess I should say, like, you have an inability or a defective hepatocellular excretion. Okay, so you have a defect in hepatocellular excretion of bilirubin, okay? Now, what does that mean? Our conjugated bilirubin cannot leave the liver. So in Dubin-Johnson versus Rotor syndrome, it's the same thing. The only thing you have to take away that's different is that on Dubin-Johnson, you're usually going to see a dark liver. So it will look grossly black. And this is usually just like found incidentally. Patient will go for like abdominal surgery, and then incidentally they will find like a abnormally black liver. Okay, and so that would be Dubin-Johnson. In Rotor syndrome, it's once again, it's the same thing to Dubin-Johnson. It has conjugated hyperbilirubinemia, but it's without the black liver. You have normal appearing liver. All right, so that's all for our liver pathologies. We're going to enter kind of next our gallbladder and then Wilson's and hemochromatosis.